घबराओ नहीं, इसको खोलो, इसको खोलो। मैं ये रिकॉर्ड यहाँ से कर नहीं पाएंगे, एब्डोमेन यहाँ से ले पाएंगे आप, मेरा ख्याल देख लीजिए। Can we start?
Yes, sir. Please.
Then time would be a factor, so I'll start straight away. Okay. So whenever we are examining a patient with abdominal problem or abdominal pathology, we already have a background based on the history, which particular organ or a system is more likely to be involved, right? Maybe can you just bolt it? Clear? So by and large, to some extent, you will know that there is an enlargement of liver or spleen, generally speaking. I am not trying to say that you take it home as a gospel truth. What I am trying to say is generally you will know patient jaundice, liver is involved, you know which organ is involved. But in all cases, what you try to do is you expose the abdomen from the nipple to, they say, to the mid of the thighs. The reason being, it's not some kind of a protocol which has been initiated for no reason. There is a very clear reason for doing so. You want to see the hernia orifices all the time. You want to see the genitalia all the time. At the same time, don't embarrass the patient. It's not simply that you pull the trousers down, pull the underclothes down and start examining. Second thing, always explain to the patient that I'm going to examine your abdomen. It is possible that the abdomen is tender. Now, if the patient is tender, your approach to the patient should be more gentler, should be more careful. So before you start actually palpating, you should have inspected very well, which does not happen, you know that. As we look at this abdomen, do not use the terms like abdomen is scaphoid shaped. There is nothing like a scaphoid shaped abdomen unless the patient is totally emaciated, totally nutritionally deprived. By and large, it will be not distended or distended. Now looking at this abdomen, it doesn't look very specially distended, but at the same time, you would wait for the patient to start breathing normally. This will put him at ease, 1. 2, you can see whether all quadrants are moving well with respiration or not. What are the various quadrants of abdomen?
There are 4 quadrants of
There are 9 quadrants, and we generally draw the mid-clavicular line down to the mid-inguinal point or midpoint of inguinal ligament? Mid-inguinal point. The other one goes right across the ninth tip of the ninth rib and transthyroid. And the lower one? Transthyroid. You know about it. So now then you divide abdomen into various quadrants. What would be the quadrant here? 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 In the center? Here? And left island. Now this is how we divide them into quadrants. Why do it? This is to make, a description of abdomen easier. You are supposed to actually describe it as one entity, but if a particular quadrant is not moving well with the respiration, then there is a pathology in that quadrant. This is generally assumed that way. Clear? Now this could be, say, right hypochondrium is not moving well with the respiration. Patient is holding his breath in that area. This is what inspection is all about. How do you inspect the abdomen? How would you be able to see the whole of it? There is one way of doing it, that you get down to the level of the abdomen. It will show you a lot of things. Abdomen is moving, all quadrants are moving well with respiration or not. The other method is to go to the foot end of the patient. As you go to the foot end, the whole of the abdomen is actually visible. Okay? Now, when you are looking at the abdomen, you are getting all the information, but you don't speak all of them suddenly. You confirm a few of them, because it's possible that one particular quadrant is not moving well with the respiration. If you observe carefully, maybe you will find that it is actually moving. It's just that you are not at the right place to observe it. Like standing here, left iliac fossa is not very clearly visible to me. That is why this positioning is important. Is that right? Now, and why do we expose it right up to the nipples?
respiratory movements.
You would like to see the movements on respiration, which is very good. What are the normal movements? Is it thoraco-abdominal or abdominal-thoracic? Abdominal-thoracic when he's lying down. What happens when he stands up? It continues to be so. So what is important is, describe that the movements are normal. Abdomen is moving well with respiration. all quadrants are moving equally well with respiration. Is that clear? Next thing that you look for if there is any fullness. Now, general fullness of the abdomen can be appreciated as, distension. You can also, when you went to the foot end, you could also see that the flanks are full or they are not full, they're normal. And at the same time, our lump could be visible. There could be a fullness, say, in right hypochondrium, which would mean that there is a lump in the right hypochondrium. If there is a fullness in the flank, what does it mean? There could be free fluid, which causes flancular, the distension of the flanks more. Looking at the umbilicus, I'm trying to be very precise, not trying to diffuse the information. Now, what do you want to see? What do you see in this umbilicus?
Very central position.
What do you want to see in this? What do you see in this umbilicus? Its shape, its position, whether it's pushed outwards or staying normally. When does it get everted? There is distension of abdomen. What all can cause distension of abdomen? There can be fluid, air, all F's, fluid, fetus, feces, etc. Now, if the umbilicus is stretched transversely, what does it mean? Again, there is something pulling from the flanks, fluid. If it is longitudinally stretched, what can be the cause of vertical distension? What all can be the causes? If the flank is okay, it can be fetus, or there can even be gaseous distension in the center. So you look at the umbilicus, I'm still inspecting. You look for any visible pulsations. In thin-built individuals, if you look carefully, there would be epigastric pulsations anyway, because they're conducted from aorta. But sometimes you see a bulge, which is different from the rest of the abdomen, and there are pulsations, so you can appreciate a pulsatile lump. And to be able to say that it is pulsatile, you should get down again to the level of the abdomen to see that it is actually pulsating. Very often what you get is an impression at a bird eye view, which is not good. Is that clear? The next thing is, once you've inspected for the position, the quadrants, movement, you've inspected for any pulsations, then you look for veins. Why should you look for veins on the anti-abdominal wall?
So we have to see the direction of veins and whether
One, if they are dilated veins, what does it mean?
whether total hypertension, severe vena cava obstruction, severe vena cava obstruction.
Can somebody sum it up? What is the meaning of dilated veins? Well, there could be a block to the venous flow, drainage, which could happen in various conditions. If there is a block to the flow in the vena cava, what happens to the flow? From below upwards, very right. And in cases of those, the one that results due to total hypertension, like Kaput meant to say, away from the umbilicus, dilated veins becoming more. If there are too many dilated veins on the chest wall, what does it mean? So you would like to look for veins all over the chest. That could indicate superior vena cava syndrome. The hernial orifices are to be examined and the genitalia are to be looked at. Don't say hernial orifices are free. There's nothing to put them into a cage. The hernial orifices are normal. There's nothing like free. They're not supposed to have hernia. And it's not that this time it is free, otherwise it normally has hernia. No. Hernial orifices are normal. Clear? So far so good? No problem? Okay. Some people while palpating try to flex the hip to relax the abdominal muscle walls. While there are many people who are of the opinion it doesn't really help. It only restricts the space where you are examining. Because flexion would release which muscles? To some extent, yes. Would it truly relieve the tension on the anti-abdominal wall? It does not. So if you're examining, you normally are on the right side. So if you really want to do it as is done as a ritual, you do the left side so that you are able to examine well. Imagine a situation where I've done this. You see the inguinal region has got already obliterated. If you start your examination in this position, it's more than likely that if you can't see, get up and see from there. There is a problem. See, as I have brought the hips up, the space is all obliterated. So therefore, I would prefer to do it this way. Maybe I'll keep it flexed. Okay? Now that was about inspection. Why should you look for genitalia? Is it a ritual or is something significant in it? One person. First of all, no. First of all, see whether their test is there or not. A missing testis could be in the abdomen and could produce a lump. A lot of times, your diagnosis can be made. Missing it can be disastrous. Similarly, if the patient has come to you with acute intestinal obstruction, abdomen is distended, you could be missing an obstructed hernia. It gets missed. In females, if you strip it properly down to the middle of the thigh, sometimes femoral hernia could be there, which has got obstructed. So it's mandatory to do that examination. That is why we do it. It's not a ritual. Clear to everybody? Now we move on to palpation. Before you palpate the abdomen, you can actually warm your hands if it is winters. Explain to the patient that I'm going to gently touch you and maybe it might hurt, and if it hurts, do let me know. It's very important to take a good consent from the patient. To have a cooperative patient is mandatory. In most setups now, you get marked negatively for not taking a consent, which is, I think, a right thing to do. You should explain to the patient the procedure you're going to do. Right? Now, थोड़ा पेट देखेंगे तुम्हारा, ठीक है? आराम से ढीला रखो और बिल्कुल धीरे धीरे सांस लो. Why should I ask him to breathe slowly? You have to do palpation when the inspiration comes. During inspiration, the organs come down and they're supposed to come into you. So you introduce your hand during expiration and you wait for inspiration to do the needful. And if you're careful, you will get most of the findings by relaxing. The other thing about which we are observing today with a lot of people, palpation should not be done with a very tight grip. You know, your fingers, particularly the tips of the fingers, are very sensitive. And if you press them hard, you don't get the sensation which you can get by leaving them alone. Just leave them gently. And you get a lot of information. They're very sensitive. And a lot of them could then palpate bifurcation of carotid or carotid, and the fingers are left to do it themselves. Clear? If you press it too hard, you won't be able to palpate. Now I want to palpate for anything specific. For that, I'll do just a superficial palpation to make sure that there is no tender spot that I will hit. So the sore area I can actually look for by doing a gentle superficial palpation. I would prefer to start from the left side because it's easier to come from distance towards you. Going this way out, I may miss some areas. So I'll just gently do it as he is normally breathing. And I'll see whether he is wincing or not. If he's not wincing, see, so I know this right side is a little tender, and I'll try and avoid it. Can you just bolt it, please? Clear? Now this superficial palpation would ensure that I'm not going to touch that sore area again. What's the disadvantage?
You're not examining the
Abdomen is going to, he's going to guard his abdomen, he's going to be anxious, plus it's cruel on the place. You're not supposed to do it. You wouldn't like it to be done on yourself. There are many people who would like to do a Valsalva before they move on to do examination of the abdomen. If you can do this Valsalva well, or cuff out well, then probably there is no diffuse tenderness, so the abdomen is reasonably alright. Is that clear? Now as you are palpating, you move from the other side to this side. I told you this is superficial palpation. I'm again demonstrating to gently tap the abdomen without pressing it too hard, otherwise the purpose is defeated. Now, you have seen that there is no specifically tender spot. You can go for a relatively, with relative comfort you can go and examine his abdomen. Suppose you want to examine for liver. You just do it, I'll then correct you. Yes? See, the problem is, now sit down. Now the problem is, you not looking at his breathing, you're just putting your hand one after another, you're just putting it, periodically without any correlation with his breathing, which is what is the problem. Now he's breathing very gently, there's no problem. So I am into expiration. Now each time, normally it will take about 4 to 5 attempts to reach liver. You should be patient enough to reach there in 4 to 5 attempts. If you want to do it in one attempt, it's going to be a problem. See, I'll wait for him to expire, and once he's done the expiration, and then I'll put my hand there and wait for inspiration to happen. Okay? बिल्कुल ढीला छोड़ो, घबराओ नहीं, कुछ नहीं होगा. हाँ, बिल्कुल ढीला छोड़ो, शाबाश. See, as I'm doing it, I reach a space or place where it's a little sore. At the same time, I can feel that liver is just about palpable. Now, what is it that you would like to see in this liver? It's palpable just now. Now, what are the various aspects of liver that you would like to see, Paras? Loudly, please. Recording.
So we like to see the margin whether it is
First of all, whether it's tender or not, because that will happen first. Then its consistency. Then you look at its margins. They're rounded or not. Surface. Is it smooth or nodular? If it is nodular, what does it mean?
so metastatic nodules, small possibility.
What is the characteristic of a metastatic nodule? They'll be umbilicated. What does that mean? Central part is depressed. What due to? Necrosis. So you look for that nodularity. You get nodularity in certain other conditions also. Like cirrhosis. What's the difference between the two? It's diffuse at a distance in case of malignancy. In cirrhosis. It's diffuse. And it's very close to each other. It's got a very special feel. The nodular, hard, metastatic liver is a characteristic finding, and one doesn't forget it if he has seen it once or felt it once. It's a hard, umbilicated nodule, and there are multiple nodules. Why does multiple, if there are multiple, why does it suggest metastasis? Yes? Why does it suggest secondaries?
Secondaries mainly comes from the portal vein, so they are spread.
Secondaries travel through the portal vein, so they tend to go along the portal tract and they end up at multiple places. A diffuse, hard enlargement of liver would be meaning what? Primary malignancy of the liver. If the liver is simply tender, it's quite possible that you may not be able to appreciate the surface very well because it's tender, so you will not like to do it also. What is it that you can do to know what the patient has? Try to look for intercostal tenderness to correlate it with some disease which is infective in etiology. But at the same time, whatever, we are focusing on the examination part. Now, the margin to me, in this case, see, the liver would automatically come and hit my finger, examine for the surface and the rest. Now, as he does it, so please watch it, that he has to take 4 to 5 steps before he reaches it. I'm just making him do what I just showed. Don't try to be in a hurry to reach it, which is where you normally miss it. You go over it and then you realize it's the same throughout. Right, it's tender, hepatomegaly. Now, what do you say of the margins? Rounded margins. How about the surface? Surface is smooth. No nodularity seen. But would you be happy with this? I mean, is that over? You would also like to see whether the liver is pulsating or not. What are the causes of pulsatile liver? Tricuspid regurgitation, or that will be about tricuspid incompetence. That is how with each pulsation the liver will be pulsatile. In a metastasis which is of a very vascular nature, it can be pulsatile, or in a hemangioma it can be pulsatile. So these are rare situations. But he has already exposed the patient further up to make sure that it is truly the enlargement of liver rather than just the visceroptosis. So you must immediately after this try to look for the upper border of liver. How do you look for that?
So I'll begin focusing on the in the
Second
middle
intercostal
second
space.
intercostal space. Angle of fluid.
Angle of fluid is identified.
एक मोटर को
That normally corresponds to,
Please hold
Yeah.
Metric.
said, I'll look for the second, I'll just repeat it for all of you. Angle of Louis, second intercostal space and he'll count it down. He'll start it from second intercostal space in the mid-clavicle line and he'll start percussing. Any difference? Now this is where it becomes dull. And he's going to tell me at what level is this. So second, third, fourth, fifth. Actually somewhere around the fifth rib. The fifth intercostal space downwards. Continue down. Okay. Use one finger only. Yes, keep going. And you trace it down to the enlarged liver. Now it's tender, and therefore we don't want to bother him too much. Maybe you'll have another abdominal to show. Now that's one aspect of examination. We have palpated the liver, it's enlarged. Don't say 2 fingers, 3 fingers, measure it in centimeters. It's enlarged how many centimeters?
Around 3 centimeters.
Around 3 centimeters below the costal margin in the mid-clavicular line. And the upper border is in the 6 intercostal space. So it's not truly an enlargement in that case, or maybe a mild enlargement. What's the upper border normally? Where is it located normally? Fifth. So there is an enlargement of liver which is tender, surface is smooth, patient is wincing, it's tender. Now if you have to examine for spleen, what would somebody like to volunteer? Yes, Shilpa? You would start from the right iliac fossa for spleen. The procedure remains just the same. I'll just show it to you once, then we'll do it. Right? With this breathing, we move our hand. During expiration, my hand is there, and during inspiration, I wait for something to come and hit me. Okay? So I'll keep on proceeding. So that's the direction of enlargement of spleen. Nothing unusual. I don't find anything. Some people like to tilt the patient to the right, cover little.